There has been global interest in health systems performance assessment over the last 3 decades. But as tends to happen, a lot of the work that has happened has been in developed or high-income countries. The World Health Organization did some very key work in 2000 when they had the World Health Report on health systems performance. And a few countries have attempted comprehensive frameworks for assessment of their systems. However, there tends to be challenges in applying these frameworks in our context in low-income countries because of the different, particularly because of the different health system agenda issues. So in high-income countries, the focus is more on containing costs while maintaining high quality and meeting expectations, whereas in our setup, it tends to be you want to ensure that basic services are geographically and by package and by different community groups, society groups available to all as we talk about the universal health coverage. So the health system agenda issues are different, and as such it means that you require different ways of assessing performance in these systems. So in Uganda, we are still struggling to come up with appropriate tools to support decision making, both at the central and the district levels. On the other hand, we tend to have multiple assessment frameworks, but which tend to be along certain lines, for example, along major disease conditions with quite a bit of overlap and then gaps. But I think very importantly, poor use of information for decision making, especially at the subnational levels. So the Uganda District League Table, which was put in place in 2003, was one of the attempts to try and have a comprehensive assessment framework at the local government level. I will speak a little bit more about this. The League Table came first with a lot of enthusiasm, but later many concerns were raised. And since we have quite a bit of experience now coming to 16 or so years, I thought this was a very interesting area to study. Maybe just to say that the chair asked us to introduce ourselves. I skipped that because I thought it was clear. But part of my interest in studying this subject was that I was part of the team at the Ministry of Health that first came up with a league table. And we thought we were coming up with a very good idea. But then later it didn't seem to be as useful as we had thought it would be. So that's the reason why I thought it was an interesting thing to study. So the indicators that were in the league table, to begin with, a few adjustments have been made since then, were input, process, output, and then especially the process and output indicators were computed into a composite index, which was then used to rank the districts from the first one to the very last one. So this was largely the basis of the league table. And you note that you'd have indicators on process or management processes, which include like the health management information system, how timely or complete this is. At this time in point 2008, the medicines were being procured by the districts from the national medical stores and joint medical stores. So this was an attempt to see whether the districts were doing as expected, buying the medicines from these entities, because these were expected to be the better quality and also cost effective. Quarterly financial reports being submitted, the primary health funds that were provided being expended, and fiscal decentralization strategy flexibility gain. This was to see if the district health system was able to lobby for more funds at the district level and thus bring in more resources to health. And the output indicators included immunization, DPT-3 coverage, outpatient utilization, households with pit latrines. This is an interesting one because it was the one that was sort of in the multi-sectoral kind of perspective, deliveries in health facilities, TB, pregnant women getting Fancida. Later, there was a composite index on HIV/AIDS service availability, and then, as I mentioned, the composite index used for ranking. So this was the league table, and this was how it was used to rank districts from the best to the very last. We put this in the context of that we have this new policy direction. From today morning's keynote address, you appreciate why I mentioned new policy direction. Is it really new? But we are now talking about universal health coverage. But we also note that the context has been quite dynamic in terms of governance and specifically in regard to decentralization. For example, we've had proliferation of districts and municipalities. So when the league table started around about 2003, we were talking about 38, 45, and 56 districts. Actually, in 2003, there would have been 56. But now, the chair, you could tell me what is the latest number of districts?
113. 113 districts.
I think more than that. The very recent ones. I think you're talking 120 or something, 120 something. So as you can see, most of us do not even know the current number of districts. So there's been this growth. Then it also begs the question of where the health sub-district is in terms of the organization of care and management, because many districts now have one or at most two health sub-districts for most of the districts. And we do not have a functioning regional level of government. And also, this league table was not looking at the other levels of care, particularly the health facilities. There was another framework supposed to do that. So my research was about finding an appropriate district health system performance assessment framework in a low-income country like Uganda. And I did this by trying to learn from international health systems performance assessment, and then looking critically at the district league table as a case study to see whether it was appropriate, and if it wasn't appropriate, what adjustments would be needed to make the league table better fulfill its purpose in the context of decentralization and decision-making, especially at the lower level of government. I used a case study approach. It was multi-phased to answer the various questions, and a core part of this was to develop a theory, to learn from other experiences, and try to understand better this whole area of health systems performance assessment, and then take this in-depth appreciation of health system performance assessment and the Uganda District League Table to try and come up with some recommendations. I used mixed methods because of the complexity of this undertaking. Because of time, I'm not able to go more into the methods, but I'm available if anyone wants to know a little bit more about that. So I used a certain definition of health systems performance assessment, and this was as a conceptually structured way of measuring the efforts of a dynamic entity, with multiple actors working in various dimensions. We've had today and yesterday a lot about the multiple actors in the health system and for UHC. And in this case, you are looking at a system whose main purpose is improvement of people's health, the analysis of such findings, and very importantly, the application of the results to decision-making. Because a key challenge I thought was that many assessment frameworks actually stop at collecting data and maybe analyzing the findings, but not so much explicitly providing for application of these findings in decision-making. So I will look at the results and the recommendations concurrently. So the first step, as I mentioned, was learning from international literature and experiences and trying to contextualize this for our own situation. So what I did was extract attributes from the health systems performance assessment literature internationally. I worked with a Ugandan-based group, experts in context and content, to validate these attributes. They added a seventh one, and then I also applied this, the normative framework that I came out with to learn lessons from international experience. So those on the right are the 7 attributes, and I'll be walking through them one by one. So the first considered attribute of a good performance assessment framework was that the process of development of the framework should really have wide participation of the different stakeholders and should explicitly use various pieces of data and models to highlight causality. Because the understanding was that both these elements would support being able to use the findings of the framework to foster decision making. In our finding, we found this was limited in Uganda, limited participation when it came to the district league table. Most of the people that were involved were national level and technical officers. And so for the future, the recommendation was that we widen participation to include technical, political, and administrative, especially of the local governments who are going to be assessed, and definitely to bring out the data and models of showing the causality of why you are using a specific model. The next element was having a clear health system conceptual framework to which you are relating your performance assessment framework. In Uganda and generally, we have a health system conceptual model. This is available in the national health policy and especially in the health sector strategic plans, the different versions of the strategic plan over time. However, you tend to have, and this has been part of the discussion over the last 2 days, you tend to have this oscillation between appreciating the wider health system and then looking more narrowly at a healthcare system. And this is quite important when conceptualizing your performance assessment. If you do one and you completely neglect the other, it means you're only getting part of the picture. Another element was to relate to the policy and organizational context. We have a particular context in Uganda, and I'll not try to go through everything. But part of it is that we've had various reforms go back and forth, especially since the 90s. We also have the challenge that although decentralization assumes a certain level of the community being able to demand for accountability, maybe that does not really take place in our context. So this is the context in which the league table has been working. And we thought there were necessary adjustments to make a performance assessment framework relate properly to this environment. So you look at acknowledging the complexity and taking advantage of the devolution we have, the decentralization model that we have. And in this case, put emphasis on data collection, analysis, and use of information at the district and lower levels. And this was unlike what has been happening very much with the league table, where the emphasis is of submitting the data upwards. Emphasize learning, adaptation, and innovation. Rather than emphasizing and saying you've done very poorly on the league table, try to understand why have you done poorly and what can you learn from how you've done, or what can you learn from what your neighbor is doing. And then related to that is the mandates. So what are the kind of health systems performance assessment relationships that we have? Largely, we tend to have today that relationship between the Ministry of Health and the district health manager or the district health office, demanding the data and as it were, assessing the district health office. And the recommendation is that the more desirable model is to consider the district as the wider district as the entity that is being assessed. So you look at the political managers, you look at the other, the social determinants, water, you look at education, you look at the administrative aspect, but you also look at the community. So these are key relationships in health systems, subnational health systems performance assessment, to actually be able to lead to improved decision making. In elaborating the framework, what kind of objectives do you have? I've emphasized supporting decision making. In the current frame, we see more an emphasis on accountability and accountability upwards by the national level being able to say, you've done well, you've done poorly. But the recommendation is that you maintain the dual objectives, but put more emphasis on supporting decision making. And also look at accountability downwards, horizontally and downwards at the district level. The indicators, one of the issues was that the indicators and a gap was noted in the process or management indicators, and there was a lot of turnover of these indicators. After 2 or 3 years, some of the indicators would be dropped. Like the indicators I showed, practically all these are not there now in the league table. And the reason was that the things were changing. If we're talking about fiscal decentralization, it's not been applying for the last few years, but now I understand it's coming back on the table. So purchasing from national medical stores and joint medical stores is no longer an issue. But still, it also points to the fact that we do not understand the management processes very well in order to use them to measure management at the district and the lower levels, and therefore to be able to build this into improved decision making. Institutional setup for health systems performance assessment is another attribute, and one of the challenges here was that the sector currently, for the past many years and still currently, does not seem to have an institutional, a good home for health systems performance assessment. We have what used to be the resource center at the Ministry of Health, and I think it's now Health Informatics Division, something like that, but it's mostly about collecting data. It's not so much about analyzing and trying to use the data for decision making. This is still scattered along the different entities of the Ministry of Health, which causes a bit of a challenge. Diversifying sources of data, including more of qualitative data, holding regular data quality assessments, building capacity for performance assessment at different levels, and creating and supporting champions for health systems performance assessment. These are some of the recommendations that came out of the findings. An important aspect or attribute for the performance assessment framework was mechanisms to elicit change. Many performance assessment frameworks seem to take it for granted that you produce data and you know that you are doing poorly or you are doing well, then change will take place. But from the different studies and from the different experiences, this actually doesn't take place like that. And you need to have an explicit plan to see how the data you have is going to cause change. So some of the proposals or recommendations for this was that league table ranking, in terms of saying you are the first or you are the last, you are in the top 10 or you are in the bottom 10, does not really support decision making. Because I'm in the bottom, so what? I'm doing badly. Yes, now I know I'm doing badly. Maybe I already knew I was doing badly, but what can I do about it? So this was an aspect that was lacking in the league table. And the recommendation here was to use various other ways of looking at the data, including cluster analysis. There is a paper on this, social network analysis, trend analysis, using manager information, stakeholder information at the local government level to try and understand why certain things are happening in that way, and also looking at peers, checking with other districts. The cluster analysis particularly helps with that. How are other districts doing? Why is my neighbor doing better than myself on this indicator? Is it because my neighbor has more resources, or is it because they are putting a little bit more emphasis in their management processes? And related to this is also how do you situate your data and information to make decisions? So as we've been talking, the core of this is at the district level. So as you can see, the big arrows are pointing to managing at the district level. You have identified the performance bottlenecks. So what do? learn peer learning, learn from friends, learn from neighbors, learn from colleagues. Put in place quality improvement initiatives. The other way of making change is from the Ministry of Health perspective. Benchmark, this district is doing well, this one is doing badly. You can support that process of seeing why the ones who are doing badly are doing badly. Put in place certain norms and standards. Maybe they are not meeting the basic norms. What is it that is happening? And then you can work through the ministry mandates of policy setting, system coordination, resource mobilization, and allocation. But the third aspect is working with the communities. And this is something that has started happening now in Uganda, public reporting. So when you provide the appropriately packaged information to communities, they can be part of this accountability and participate in decision making. And this, it's expected, will support better decisions for better services. So the last one was adaptability of the framework. The league table as it is now has seen a number of changes, I think like 4 changes now. But most of the changes are by the technical people at the Ministry of Health. And they tend to be marginal, change a few indicators, give special status to Kampala, and so on. So they've not been a broad or systematic review of the league table. So that's one aspect. The other aspect is that, as we mentioned for attribute number 1, you need to involve more people, you need to involve more data in trying to determine whether this is the best way to have the kind of performance assessment framework and build in some dynamism and flexibility. For example, local government might decide to, adapt a different way of looking at it. Look at the regions. Maybe do you want to study a few more of the regions, or do you want to pick out districts with similarities, border districts, looking at the level of resources that are in the districts? What do you want to look at? And lastly, do you want to rename this? It's been 13 years. Like the discussion on UHC and PHC and health for all and so on. Sometimes people do well with a change in name, and then something seems to be exotic and new and maybe more interesting. So do you want to retain the old name, or you want to talk about something else? Lastly, this is a very kind of relatively new area for us. And there are so many things that one needs to understand. And so there is a lot more that can be done in terms of research and learning together with local, especially academia, Ministry of Health, other stakeholders, and then working together with the local governments and the communities. So I've put some of the areas out there. For example, the fact that you have to use, or you might need to use, the double-pronged objectives of supporting decision-making and accountability. So how does that work? Because accountability, especially upward accountability, tends to take more emphasis. And these numbers that we do and the ranks, and so, they are usually much better useful for people at the higher level to see. WHO does it for the whole world, to be able to make a table and see this is the best, this is the worst. But in terms of decision-making, does that actually support, is it very meaningful to decision-making? I'll not go into the detail of the other ones. Just to show you some of the papers that we published on this, and if anyone is interested, we can discuss and have a look at this. So the first one was on learning from other experiences. The second one was a case study on the Uganda District League table, particularly from a historical and policy analysis perspective. The other one was using a more quantitative approach. Thank you for listening to me.
Thank you very much, Christine.